Hi there, I'm Matt Reed and I'm a Professor in Emergency Medicine in Edinburgh. I'm delighted to join you for the National Journal Club meeting this month and absolutely delighted that you've chosen the DASH study to look at. I'm not sure whether I'm going to be able to attend personally, so I've been asked to record just a few minutes to give you my thoughts about the clinical implications of DAShED. So we know what the problem is. We know that we misdiagnose 1 in 3 patients who have acute aortic syndrome. We know we don't think about it all the time, which is one reason we miss it, but we also know it's very difficult. And the reason it's very difficult is that patients can present with a multitude of symptoms which are associated with AAS. And it's extremely difficult because these symptoms are very common: chest pain, abdominal pain, back pain, new neurological deficit. And we know that more than 2 million patients present every year to England EDs with chest pain. Just giving you an idea how large that cohort is of patients who have symptoms that could be compatible with AAS. We know that there is a diagnostic test that is very accurate, the aortic CT angiogram, but we know that we can't do that on every patient that presents with symptoms that are suggestive or even compatible with an AAS, because even if we had all the CT scanners in the world, if we CT'd everybody, there is a significant ionizing radiation risk. And we know that 1 in 200 patients who undergo CTA have a lifetime risk of a malignancy associated with that. So we have to try and better differentiate which of those millions of patients that present need to undergo scanning. And I think in emergency medicine, we're very aware of this huge undifferentiated population that might not be quite apparent to some of our specialty colleagues who see a very differentiated cohort that we've referred on. And it was this underlying problem of the population that we see compared to the population that is much more differentiated, that some of these clinical decision rules and D-dimer, for example, have been tested in, certainly in other countries as well. So the whole purpose of DASH was really to describe this baseline population and of all the ED tendencies that we see that present with symptoms that could be suggestive or compatible with aortic syndrome, acute aortic syndrome. Because we're recruiting a large cohort of patients, we also thought we would have a look at some existing clinical decision rules and how D-dimer performs in an all-comer group, an all-comer undifferentiated group, compared to more differentiated groups in specialist centres. And certainly this is the first study that has ever looked at this, and certainly no one's looked at it in the UK population as well. So what are the take-home messages and implications of DAShED? I think most importantly, about the 5,500 patients we considered an acute aortic syndrome was a realistic possibility in 1 in 4 patients. But only 7% of all of our patients actually went on to get a CT angiogram. And we didn't miss any patients with aortic syndrome. So this implies that there is some clinician decision-making, clinician gestalt, that is choosing which of these patients that could possibly have AAS should go on and get a CT scan. And this has implications for guidelines. For example, the current ARCHIM guideline that suggests that if a patient has any ADDRS factor, they should get a CTA, would lead us to scan a lot more patients than we're currently scanning. And DAShED shows that. DAShED also showed that only 3% of all the CTAs we did were positive. And this is fine for a condition that's rare, that's so catastrophic if it's missed. It's very acceptable to only pick up AAS in 3% of patients. But the more scans we do, the lower this will drop. But it gives you an idea of the number of patients who go on to get AAS. And in our cohort of 5,500 patients, obviously it was 0.3%, so 14 patients. We did have a look at some of the decision rules, but because of our 14 patients testing positive and being diagnosed with AAS, it wasn't really possible to make any meaningful conclusions from this. Where does DASH leave us a year or so on? Since DASH, there have been a couple of studies published. The ACES study led by Steve Goodacre in Sheffield, and also the Profunda study from Italy. And I think these studies have really tried to give us more information about which of this huge underlying baseline population of patients that present with possible AAS, or symptoms that could be compatible with AAS, the DASHED cohort, should we go on to get a CTA in. It's fairly uncontroversial that if a patient has an ADDRS of 2 or 3, we should definitely go on and get a CTA. That's unquestionable. We do know if we CTA everybody with an ADDRS of 1, for example, that's probably leading to too many CT scans. We know D-dimer is helpful. We know a negative D-dimer is very helpful, even more so if the patient is of lower risk. But if we D-dimer everybody who is in the DASH cohort, we would massively increase the number of CTAs that we need to do. So we can't just D-dimer everybody. Could we use ADDRS and D-dimer together? Well, that's probably the way we're going. It's likely to reduce the number of CTAs that we do, or that current guidelines suggest that we do, and is probably a cost-effective strategy for the NHS. So what do current guidelines and clinical decision rules suggest relating to D-dimer and the thresholds we should have for CTA and D-dimer? Well, it's a real mixed bag, as you can see from this chart here. So with an ADDRS score of 0, the Canadians would suggest we do nothing further. The ADDRS score would suggest D-dimer, and going on to CTA if the D-dimer is greater than 500 fibrinogen equivalent units, obviously 250 if you use the DDU, D-dimer threshold. ACEP would suggest D-dimer, and RChem would suggest no further investigations. About the intermediate group, those with an ADDRS score of 1, Canadians would suggest D-dimering, as would the ADDRS, whereas ACEP, the new ACEP guidelines released in the last few weeks, would suggest going straight to CTA, as would RChem guidelines. Finally, if you've got a high-risk population with an ADDRS score of greater than 1, so 2 or 3, unequivocally, we would all the guidelines would suggest going straight for CTA. But it's this bit around where is the threshold drawn for CTAing and D-dimer testing in the low and intermediate threshold, which is likely to be the basis of much more work in the next few years. Thank you for allowing me to contribute to the meeting today. It's been a real pleasure to be involved. Thank you very much.